Now let's move on to the next session of the plenary. The topic will be Proliferation of Surgical Technologies and its impact on fellowship training for developing countries. Over the moderators to introduce the speakers.
I call upon Dr. Rohan Hall, Consultant Urological Surgeon from Bendigo, Victoria, Australia. Over to you, sir.
Thank you. Thank you, President Manjula and the SLAUS Committee for inviting me to your lovely country to deliver hopefully a bit of a different talk on robotics and the impact on training. We've had some great sessions so far. Danielle, I really love the concept of flipping training to different things with regards to open versus laparoscopic. I have a great respect for Sri Lankan training. I think you should be very proud of your reputable and robust selection and training program. Traditionally, 1 to 2 years are spent training abroad to gain subspecialty skills for high volume centres. This map represents a distribution of robotic surgical units in 2016. There were 3,800, and this has doubled since that time. Robotic surgery, as we all know, offers many advantages for complex reconstructive surgery. We've seen some fantastic videos this morning with great music as well. But obviously it offers with 7 degrees of movement with the endo risk compared to the traditional 4 degrees of movement with pure laparoscopic surgery. There's tremor reduction, there's improved 10 times magnification with 3-dimensional vision. The list goes on, and this all contributes to an advance in surgical instrument. There is a host of literature pointing toward improved outcomes relating to these features. But how do we interpret robotics in the literature? Look, there may be advantages, but without meeting clinical significance. And I think a lack of evidence doesn't mean it's not true. It just means it hasn't been shown yet. And language is marketing. I think it's important that, improved vision may offer improved nerve spare. That doesn't actually equate to every patient still going to have an erection. So patients and clinicians ask for robotic surgery. Why? Is it the ergonomics? Maybe. Is it the outcomes? Maybe. So when we look at the literature, and I think the best constructed randomised control trial in this space was that comparing open and robotic-assisted laparoscopic prostatectomy by Jeff Coghlan and John Yaxley in Brisbane. It's been well publicised and well discussed. It showed no difference in cancer, continence and erectile outcomes. There was 300 mils less blood loss and a shorter hospital stay. So let's look at the cost and the things that we need to consider if we're thinking about starting robotic surgery. There's the cost of the robot, and that varies based on which robot it is, and that's somewhere between, in Australian dollars, 1.5 million for the Mantra SSI, to now the new Da Vinci 5, which hasn't been released in Australia yet, but I'm told is approximately 5 million. There's also the $150,000 roundabouts for the CSSD. There's $350,000 annual service fee. There's potentially redevelopment of the theatre complex to accommodate the robotic cart and the bedside cart, particularly with its weight. There's training and a learning curve and productivity of theatre. I think we need to think about all of these things. So when we look at the costs associated with this, whilst there's been multiple publications demonstrating advantages of robotic surgery for the surgeon and the patient, the cost remains prohibitive for many institutions. Cost per case is volume dependent, and as the fixed purchase and the setup costs are then spread across multiple procedures. It takes about 150 cases, so it's estimated, and this has been published a number of different times, 150 cases per year to break even. And to become cost effective needs to be at least 250 cases per year. I think congratulations to Pakistan who have developed a robotic program with combination between private and public sector, and there's enough funding for, the last thing I read was 150 cases per annum, so it's fantastic to get that up and running. And it may take those collaborations to get things going. So if we look at the cost and the individual cost associated with robotics alone, comparing robotic-assisted radical nephrectomy compared to laparoscopic or hand-assisted laparoscopic nephrectomy, the difference is approximately $2,200 per case, over and above the pure laparoscopic. And when we look at that in the prostate, it's been published that this is approximately $4,000 per case. It depends on the number of instruments you use, and as we refine our techniques, you may be able to get by with less instruments, bringing that cost down. The Sri Lankan health budget, well, while Sri Lanka is a relatively small country, it has a large population spread over vast communities, and accessibility and costs offer barriers to centralisation. I think it's really important that we recognise that the public sector provides nearly 95% of inpatient care in Sri Lanka. So if we then flip that to Victoria, which is where I'm from, and we look at the Department of Health in Victoria, and this is my apology slide, Ian, that it is busy, but I'll walk you through it. I don't expect you to read all that. But in September of this year, the Department of Health in Victoria re-released their policy on robotic surgery in the public sector. So in 2016, if I take you back, the Victorian Department of Health put a stop to setting up robotic programs in the public health system due to a lack of evidence and prohibitive costs. This was revisited in 2019 and again in September of this year. Regardless of the recommendations, Victorian public hospitals have the largest number of public robotic surgical units in our country. So I'll walk you through what they had to say. They said evidence for robotic-assisted surgery is superior, and this remains inconclusive. Despite limited evidence, robotic-assisted surgery uptake has been primarily driven by workforce and patients. Things to consider are cost effectiveness, we've already gone through this, but impact on throughput, extra infrastructure, cost of maintenance, and the cost of disposables. And of course, we need standardisation in training programs, and hospital governance frameworks need to be established. So some thoughts about the health policies. So robots are installed regardless of evidence because of popular demand. The same is likely to occur in Sri Lanka, albeit maybe a bit slower. Focus needs to be on efficient delivery of healthcare and the largest number of patients within the confines of the health budget. What is the minimum skill set required to deliver safe, efficient urological healthcare to the people of Sri Lanka? And when we look at lessons from Australian urological training, we say, well, what are the requirements for a trainee to get access to that robotic console? An example from a large hospital in Melbourne are they need 5 inpatient case observations, they need to complete online intuitive surgical training modules, they need a minimum of 20 hours of simulation training, they need to score at least 90% on primary and secondary simulation exercises, then there's dry lab and docking training, and to review some procedural videos, similar to the ones that we've looked, which are obviously very impressive. What other things have we seen? Well, let's ask the trainees. In the initiation of new robotics programs within the hospitals, there's been complaints by trainees about access to console time due to upskilling of consultants. This seems to then have a lag time to then allow the trainees to get access. That's an issue. And there's certainly been a reduction in the major cases on logbooks. This was also published in 2021 in the NHS, exactly the same results. So lessons from the Australian Urological Robot Credentialing. So what are the requirements to operate independently as a consultant? Well, there's an online course, there's surgical intuitive wet lab course, there's a minimum of 4 proctored cases, and that's it. Okay, so the focus on urological training, I think most hospitals will not have a robotic assisted surgical unit. All skills should be acquired based on need. Learning curves need higher volume centres. We've heard that today. Laparoscopic for minimally invasive access to retroperitoneal surgery and some pelvic surgery. Open for complex abdominal and pelvic surgery. And robotic fellowship, setting in overseas high volume centres. It only makes sense. Trainees need to be confident in all aspects to safely convert, attend intraoperative referrals and manage a broad range of urological conditions. So solutions for the future? Well, establishing robust overseas 12-month rotations with public hospitals that do not have a robotic system, which would dilute open and laparoscopic cases. But these are likely to disappear with time as more public hospitals install robotic systems due to popular demand. For the time being, consider robotic training a fellowship training skill set, which is optional. And as the number of Sri Lankan urologists increase, Sri Lanka can become self-sufficient with high-level training in high-volume centres. Thank you.
Thank you, Rohan, for that very valuable insight into technologies and the future trends in training and how it can apply to Sri Lanka. On behalf of the Urological Association of Sri Lanka, I would like to present this small token of appreciation.